Well, thank you very much. It's a great pleasure to be here this morning and get to talk to you a little bit about mental health problems, primarily in children and adolescents with autism or autism spectrum disorders. And I'm very conscious I'm taking up the sort of last slot before we have a general discussion, and then I'm standing between you and your lunch, or at least you and your coffee. So I'm going to try to make this relatively brief and also focus on, I think, issues that should be pertinent to your work. I just wanted to highlight where the funding for some of the research that I'm going to present from our group comes from. And then I really wanted to sort of highlight what are the main areas I want to cover. First of all, I am going to focus on autism and mental health problems in autism. And I'm going to start by talking about the findings from both epidemiological studies, but also other population-based studies, because it's absolutely crucial. If we want to know how common problems are, we don't look at clinical populations, but we look at general populations. And I will show you that those rates are much higher than we would have expected, just like the last speaker has shown us for intellectual disability. And I'll think with you a little bit about why that might be the case, but then quickly come on to, so what do we know about interventions? And that's really to inform you as to what you should expect if you're working with children with autism and you think they have mental health problems. So, in terms of the rates of mental health disorders or psychiatric disorders, I'm going to focus on two studies that I've been involved in, not because they're the only studies, but because they are representative of the literature more widely when you look at population-based studies. And the first is the Special Needs in Autism Project, SNAP, which is a study of 12-year-old children ascertained from the general population. All of them had a statement of educational needs, and we saw them initially in the early 2000s, did a gold standard autism diagnosis, and then looked as well at mental health disorders. The second sample, and I should say that they've been followed up at 16 and now at 23, and also I'll give you a little insight into what those later data are looking like. But we also wanted to look at mental health problems in younger children. For that, we used a community-based sample. That is all children who received an ASD diagnosis in two London-based child health clinics. So this is not epidemiological, but it is an entire community sample. In this sample, they only have a clinical ASD diagnosis. But a particular advantage of that study is that we were able to look at many more girls, and there's always a question of what does autism and indeed the associated mental health problems look like in girls with autism. So that's a special advantage of that study. So what did we find? Well, this is from SNAP at age 12, and we undertook, as we heard, clinical interviews are the gold standard for saying that there is a child mental health problem. We used the child and adolescent psychiatric assessment in our sample, and we used the same approach and the same diagnostic algorithms as my colleagues in the US were using in a general population study. And that's really important because you can put the thresholds for where you count something as a disorder at very different points and get very different rates. So for example, if I'm wanting to assess is depressed mood present, I need to say, well, how severe does it need to be? How long does that need to last? And over what period, when the person's feeling depressed, and for what length of time? If you vary any of those parameters, you will, on the single symptom of depressed mood, get very different rates. So we used exactly the same algorithms as our colleagues in the US, and therefore I feel confident in comparing these rates. So in our sample, just under 70% of our 12-year-olds with autism had at least one psychiatric disorder, and just over 60% had what I call a common emotional or behavioral problem. And we'll see that what I'm including in that are emotional disorders, conduct and oppositional problems, and ADHD. And that just over 60% compared with 10% for a general population sample. So we just heard about intellectual disability with maybe a 4 to 5-fold increase. Here we've got a 6+-fold increase. We were really quite shocked at this, and we went on to look at our 5 to 9-year-olds in our other Quest community sample. And what we found here, again using now not the child and adolescent psychiatric assessment, but the preschool and primary school assessment, so really the junior kappa, and again comparing to our colleagues in the States on a general population sample, that we had even higher rates, 90% of any disorder, and as well any emotional or behavioral disorder, and that compared to a very much lower rate in the general population. So consistency across two samples at different ages. So what were the common disorders? Well, here you can see the two samples pitted against each other, and you can see that ADHD, oppositional defiant and conduct problems, and emotional disorders are the three common ones. I think there is a sort of methodological warning here, which is the PAPA, the measure for younger children, many of us think has very lenient thresholds for emotional disorders. So what looks like a huge increase in emotional disorders amongst the younger group probably is more reflective of the different thresholds I was talking about early on. So the comparison to general population still pertains because we used exactly the same measure, but I think I wouldn't want to go so far as to say emotional problems are more common in 5 to 9-year-olds than they are in 12-year-olds. I think this is an instrument issue. And probably if we applied similar thresholds, you'd get very similar sorts of rates. Okay, and again, this is perhaps more for clinicians, but this is showing the rates of the different anxiety or emotional disorders. I think there are really just a couple of things I want you to take away. That in childhood, depression appears still to be uncommon in children with autism, and not particularly increased over the general population. However, the big areas that we saw as problematic, and I hope this will have some resonance for you, around generalized anxiety, which is the general worrying and ruminating and getting really stuck on worries that needs to be distinguished from the autism-based ruminating and liking to have ideas go over and over in your head. These are distressing ideas that keep children awake at night and concern them and make them distressed and unhappy. And the other one being social anxiety. And typically we used to think that children on the autism spectrum avoided social situations because they weren't interested in social relationships. But what more recent research has shown quite clearly is that a component of avoidance of social situations is actually around anxiety and distress around social situations, and possibly around the uncertainty and the complexity that social situations require of the individual. Okay, so the purpose of this slide is really to show you that the kind of disruptive behavioral disorder that is common in children with autism at both ages is the oppositional, defiant, non-compliant behavior. It isn't what, as a psychiatrist, I would call conduct disorder, which is stealing, truanting, shoplifting, being involved in vandalism, issues like that. It's that sort of really refusing to comply with expectations and being very disruptive when asked to do things. And finally, we did, of course, see that ADHD is common at both ages. So there's a slight mistake on the slide. It shouldn't be data at age 12. It actually is showing you both age groups here. And in terms of tics or Tourette's, those have been combined for the 5 to 9-year-olds. So take those first two sort of purpley columns and add them up to, you'll see that tics or twitches, in fact, are very common. And these are important if you're working particularly in educational settings, because they can be difficult to distinguish sometimes from stereotypic or mannerisms. And they can also be mistaken for disruptive outbursts, particularly if they're vocal tics. So that's important to be aware of. And the common sleep problems, and also problems with wetting and soiling. So that's really just to give you an overview of the kinds of problems or mental health problems that children with autism experience. This slide is to show you how the common disorders overlap. So I think it's very easy to get trapped into the idea that, oh, this child with autism has ADHD or they have an emotional problem. What I want you to take away from this is that in both our age groups, the overwhelming majority of children who had one additional mental health problem had more than one. So many children with ADHD plus an anxiety disorder and some oppositional defiant behaviors. And we need to think not just about a single problem in a child, but the multiplicity and the complexity of the difficulties. And in terms of interventions, we need to be able to develop hierarchies for intervention and to think about how the different elements are contributing to the child's presentation in the social situations in which they find themselves. Okay, and then just very briefly, because I know that sex differences in autism are of such great interest. As I said, in the Quest sample, we did have enough girls to have power to look for sex differences. Do remember that this is amongst those who received a diagnosis, so it's not addressing the question that's often raised of are girls with autism being missed? It's amongst those who have autism, do they look different? And in terms of sort of demographic features or characteristics of the children, girls with autism had a slightly lower IQ, but that was significant. In terms of their scores on the autism measure, the social communication questionnaire, there were no differences, nor were there differences in terms of parental characteristics in relation to parental ethnic background or parental educational level. When we looked at mental health problems, I'm only showing you the significant differences here. So we found that boys were more likely to have oppositional, defiant behavior. They were more likely to have ADHD, and they were also more likely to have tics. But there were no differences, particularly in relation to the emotional disorders between boys and girls. Now, are these problems important? Is this just rating autistic behaviors in another way? Well, this slide shows us in our SNAP sample the persistence and specificity of the problems across two different ages, from 12 to 16. So we've just heard in the last talk about the strengths and difficulties questionnaire and the core disorder domains of hyperactivity or ADHD, conduct problems, and emotional problems. And I've added into this slide the social responsiveness scale, which is aimed at measuring autism symptoms. So we think of those as a relative constant in children with autism. And the correlation, so this is how similar are children at 12 to how they are at 16. The correlations on the diagonal are the ones that represent the same behavior at 2 time points. And what I'm aiming to show you is that these are actually relatively high correlations for emotions and behaviors over 4 years. And they are of the same magnitude as the autistic symptom continuity and the SRS over 2 time periods. And they're also of the same magnitude, if not slightly higher, than you would see in a clinic population without autism. So problems are both specific and persistent over time. And this is just a very first peek at our data at 23. So this is looking at the Strengths and Difficulties Questionnaire, not just the 3 domains of behavior, but also peer problems and pro-social behavior over about a 12-year period in these people who are now young adults, again, showing you a pattern of specificity and persistence over time. So if you're identifying mental health problems in a child with autism, they are likely to persist over time, and just thinking it's going to go away is not a useful strategy. Why do children with autism have increased rates of mental health problems? Well, we're not entirely sure. In our SNAP sample, when we looked at the 16-year-old data, we were able to take a number of characteristics from the children and their families at age 12, which are those in your left-hand column, and look at what they predicted to at age 16 in terms of the SDQ score. So this is really a true prediction to subsequent problems. And I should say that we looked at about 8 different domains of risk factor. These were selected. The sample wasn't originally aimed at identifying mental health problems, so we had to be opportunistic in seeing what measures had we collected at 12 that we knew in the general population are risk factors for mental health problems. And we identified some, in fact, 11 risk factors, and then we're looking across 4 different domains of behavior. So that gives you a possibility of 44 significant associations. And these are the only significant associations that we found. IQ and adaptive behavior, which is very closely related to IQ, although importantly, more impaired in people with autism than you would expect on their IQ alone. IQ and adaptive behavior predicted the total SDQ score and also hyperactivity. The maternal GHQ, that's a general health questionnaire, and that's a measure of maternal mental health, as you can see. So largely picking up anxiety and depression, and that predicted to emotional problems in the children. Social class, you can see, also predicted emotional problems. Area deprivation, which is how deprived is the area in which the family lives, and that's based simply on their postcode. It's nothing about the individual family, predicted to conduct problems, but family level deprivation. What did your family have access to in terms of really material possessions, predicted to emotional problems. But there was, in general, a lack of prediction compared to what you would see in the general population, where you would see many more significant relationships. So that's led us to think about different models of why people with autism may have increased rates of mental health problems. And I'm only going to touch very briefly on these because of time, but what I'm going to want to focus on is the fact that that ADHD almost certainly occurs in part in ASD at increased rates because of shared genetic risk factors, whereas in terms of anxiety, it's probably at least in part due to elements of autism that increase the risk of developing anxiety, and also the exposure to environmental events. So in terms of ADHD, we sometimes use what we call a behavior genetic model, and this is using twin data to look at whether the reason why two different behaviors, in this case autism and mental health problems, are due to shared genes or shared environment. And what we found in ADHD is that the reason for the link between ADHD and ASD is due to that correlation that you can see at the top between genetic factors that affect both disorders. So this was a study done based on ASD and ADHD traits, but also if we look at the Scandinavian data, we show a similar shared underlying genetic liability. So these are the 4 different disorders and why and whether the co-occurrence with autism is due to genetic factors or other factors. And the red bars indicate the proportion of the explanation that is due to shared genetic factors between the 2 disorders. So you can see in your left-hand column there that the majority of the reason why ADHD and ASD co-occur is because the underlying genetic factors overlap. And I'm going to very quickly jump over the next slide simply to say that our initial look at molecular genetics, looking for the actual individual genes that may cause ASD and ADHD, it's still in its infancy, but it is demonstrating that some of the genetic risk factors at a molecular level, at the biological level, are risk factors for both ASD and ADHD. So we think that that's an important reason for the overlap between the 2 disorders. But of course, it's not necessarily very helpful in knowing what to do about it. Well, many of you, exactly, what are you going to say to the children and families? So many of you will probably have experience of other children that you've been involved with without autism, having ADHD and receiving treatment for ADHD. And we can have that discussion in our discussion time, but arguably the most effective in terms of reducing symptoms treatment for ADHD in the general population of children has been a variety of medication strategies. So 3 different medications have been trialed in children with autism who also have ADHD. And this slide shows you what I call an effect size. So an effect size can take on a negative number or a positive number. And it's simply a way of standardizing across different studies with different measures, outcome measures, how effective is a treatment. 0 means that there's absolutely no effect at all. In general, we describe an effect size of 0.2 to 0.4 as a small effect size, an effect size of 0.4 to 0.6 as a large effect size, and effect sizes of 0.7 or above as large. To give you an example from your perhaps general experience, if we use antihypertensive blood pressure lowering medications to reduce the rate of having heart attacks, that has an effect size of about 0.3. So it's really in the moderate category. And this slide shows you the effect sizes in a number of studies for methylphenidate, MPH, atomoxetine, ATX, and guanfacine, GFX there, the 3 medications that have been studied in ADHD and autism. And you might take away from this that you should always use guanfacine and then atomoxetine and then methylphenidate. In fact, methylphenidate has been the most carefully studied medication and also has the largest sample sizes. But in addition to these effect sizes, we want to look at what we call the clinical responders. So this is when you're undertaking an evaluation of medication, someone who doesn't know what treatment the child is receiving gets information from the family, sometimes the teachers, observing the child, and puts it together to describe how much they've improved. And that's collapsed into a measure of are they a responder or a non-responder. And what you can see here is that actually the rate of responders to methylphenidate versus the rate of responders to placebo, because of course some children get better even though they're given a dummy tablet, is actually quite a large discrepancy. And there were a higher proportion of responders to methylphenidate than to atomoxetine. Now, Guanfacine is the new medication on the block, and it needs further evaluation, but it's looking promising. And what that means in terms of intervention, for those of you who are working with children and wondering what you should expect, is that we would still recommend that medication should be considered for moderate to severe ADHD as part of the treatment program, that we would usually recommend, unless there are specific contraindications, that you start with methylphenidate, and if there's either a lack of response or adverse effects, that you might switch to atomoxetine or guanfacine, and that you would consider a psychosocial intervention at the same time to modify the environment appropriately to help the child with their ADHD symptoms. Okay, the second domain I want to think about is anxiety. And this was the single most common problem amongst children with autism. It's also the area that the Autisticus survey of parents, carers, and people with autism themselves said was the single most distressing problem. The genetic studies that we looked at for ADHD do not suggest that there are shared underlying genetic factors that are responsible for the overlap between anxiety and ASD. And so we wanted to look at whether some of the components of ASD itself might predispose to anxiety and also depression, because the two very often co-occur. And this was work done by one of my PhD students who looked at two of the cognitive domains that are often impaired in people with autism. So social cognition is, we're thinking of things like theory of mind, perspective taking, emotion recognition, that ability to recognize other people's emotions, say in faces or in acoustic stimuli. And executive function, which is the ability to organize and plan, and also to respond flexibly when situations change. And Matt tested whether, and of course both of these cognitive domains are strongly influenced by IQ, so we wanted to take account of that in the model. And Matt was testing which of these two, or indeed both domains, accounted for the anxiety and depression that we saw in the sample. And he got a very clear answer to that. It was not the social cognition that was associated, but rather the executive function, the planning, organization, ability to respond flexibly. And I should say that Matt's work has also suggested that children with anxiety and autism have a blunted physiological response to anxiety, which suggests that they experience anxiety fairly chronically and consistently over time. It's really suggesting that it's a fairly, for those who are anxious, it's a fairly persistent feeling. Okay, so we also know, for example, that factors like bullying and life events are increased in children with ASD, and we're looking now in our follow-up study to see how much they play a role both in mediating and predicting anxiety over the life course for people with autism. But more importantly, what does anxiety relate to? And we also looked at how anxiety and irritability are related to each other. And so we looked at both parent and child correlations between anxiety. They actually agree pretty well on whether the child is anxious. They agree pretty well on whether the child is irritable. Parents cannot really discriminate between, that's one way of thinking about it, between anxiety and irritability. So if they say their child is very anxious, they also say, well, oh, it's gone off on my screen. Sorry, my screen had gone off. They also say that they're very irritable, whereas children do not. Children see anxiety and irritability as different domains. But this, I think, is really important because Very often we're obtaining accounts from parents about their children's symptoms. And if a parent is telling you that their child gets angry easily, sort of has meltdowns with the slightest trigger, or indeed without an observable trigger, think anxiety. What may be driving this external manifestation of irritable, non-compliant, very distressed behavior may in fact be underlying anxiety. And very quickly on this slide, what I want you to take away is that we looked at our sample of anxious children with autism in levels of irritability. Both the parents above and the children below. And we've graphed here the 7 different irritability symptoms, and we've compared them to a general population sample, which will be the lower lines in each case, and to a sample who got the new DSM diagnostic manual diagnosis of disruptive mood dysregulation disorder. So who are actually getting a diagnosis for irritability. And what we're finding is that our anxious children have the same very high rates of irritability that we'd see in a group of children who actually have a disruptive mood dysregulation disorder. So irritability, think anxiety. Not always, but it's a really important element. What do you do? Well, this is another slide showing effect sizes in a slightly different way. So they're presented, the different studies are presented as individual rows, and the 0 line, again, reflects the no effect of treatment. So what you have are the individual trials of cognitive behavior therapy, each plotted, and then at the end in your sort of this diamond on its side, you have the average over all of those studies to get a better estimate of the effect of cognitive behavior therapy. And because the edge of that diamond does not go through 0, this shows us that the studies of cognitive behavior therapy for children with anxiety and autism are showing a significant benefit. There are some important caveats about the quality of the studies, and it's also really important to know that the CBT that was used in these studies was modified specifically for children with autism. Children with autism often cannot access bog standard CBT. It needs to be delivered by someone with autism expertise who modifies the intervention to be more appropriate for children with ASD. But that currently would be the first line of intervention. We do know in general populations of children that medication does have a beneficial effect in reducing anxiety, but where there are currently no studies of medication, I'm talking about the SSRIs, fluoxetine or Prozac and that class of medication, there are currently no studies of the SSRIs for anxiety and ASD. So I think the recommendation has to be start with CBT, but because we know the SSRIs can be beneficial in non-ASD children, you do need to consider those either in cases of children with such severe anxiety they can't access CBT, or in those who aren't showing an adequate response. Okay. Wind up. Yeah, I do want to touch ever so quickly on challenging behavior, and I have left it to the end because what I want you to take away in terms of challenging behavior is think first about ADHD and think first about anxiety, because we have well-demonstrated effective interventions that are specific for those conditions. And there's a challenge with ASD that you just see the behavior and you label it challenging behavior and don't look for the underpinnings. So think first, and this is my slide showing sort of some of the pathways to challenging behavior that I think are critical to to consider when you're thinking what causes challenge in behavior. Just very quickly to highlight the NICE guidance, we heard about the recent NICE guidance coming out for learning disabilities and NICE guidance for management of problems in children with ASD, recommend that you start with a behavioral approach first to reducing challenge in behavior, and then that you consider medication either when that is insufficient on its own or when, again, the behavior is so severe that a psychological approach initially is inappropriate. This slide, again, more effect sizes, shows that medication, the atypical antipsychotic, risperidone, is hugely effective in the short term. These are big effect sizes. This shows you that aripiprazole, another atypical antipsychotic, more expensive but possibly with fewer adverse effects, is also effective. And this shows you that risperidone continues to have beneficial effects even when extended over a relatively longer period of time. So it's a really important part of your armamentarium. But NICE highlighted that we should not be thinking of using either risperidone or aripiprazole or indeed any of the other atypical antipsychotics for prolonged periods of time. You should be seeing them as a briefer intervention where you're always trying to allow the behavioral and environmental interventions to have their main effect, and that prescribing should be monitored over the longer term with an aim to discontinuing. So it's really important to remember that if you're involved with children who are receiving these medications. And that's because they can have significant toxic effects. So in conclusion, mental health problems are extremely common. They are the rule rather than the exception in children with autism. ADHD, anxiety, and severe non-compliant and disruptive behavior are the most common domains. They have specific interventions that make the differential diagnosis essential, but you need to be aware that most children who have one area of difficulty will have several, and you need to be able to prioritize your interventions. Thanks very much.